in Australia that were released in March this year, pretty much mirror the NICE guidelines from the UK, and I think really do emphasise some very, very important points. Three of the people who are on the Guidelines Committee are here today, and it's a real delight to have these out. I think they're a very significant document. There are 63 recommendations. You can download this for free off the internet. There's 278 scientific references. There was a lot of work. There was 49 submissions to public consultation, and there were 8 key recommendations. And these are they. The first one is that BPD is a legitimate diagnosis for healthcare services. This might seem like a no-brainer to a conference like this today, but to me it's an extremely important message where lots of mental health services have said we only do people with psychosis, or we only do people with depression, we don't do people with personality disorder. And that kind of negative message, I think, now needs to change. I think the National Health and Medical Research Council, by putting out these guidelines, has made a very strong statement that BPD is part of the mental health service, that we need to be taking this diagnosis seriously, and we need to be rethinking the way we provide services. The second is structured therapy should be provided. Medicines should not be used as a primary therapy. Treatment should occur mostly in the community. Adolescents should get structured help. Consumers should be offered a choice. Families and carers should be offered support. And young people should be assessed. I think these are very important key messages. Interestingly, lots of people like Sathya, for example, are now saying, how can we operationalise these guidelines into clinical practice? Interestingly, we already have a model of how good guidelines-based treatment works in actual practice. So John Gunderson, who's one of the key leaders in the field, developed these good guidelines-based psychological management guidelines, and they were compared to DBT in the largest randomised controlled trial that's yet been done. So this was DBT versus good clinical care based on guidelines. What happened in the guidelines was once-a-week individual meetings with a focus on the person's priorities, psychoeducation about their problems, a here and now focus, so how can we improve your functioning today and tomorrow, a focus on emotions, relationships, and, if useful, hospitalisation. The findings were equivalent outcomes to DBT, which is a more expensive but a very, very effective treatment. And I think what this shows us is that we don't necessarily just have to build more and more DBT programs. I think the DBT has a fantastic evidence base, but also lots of clinicians who don't have DBT training can also do good work if they follow guidelines. And if you look at the reason why lots of the treatments do show equivalent effectiveness, it's probably because all of the evidence-based treatments have these 4 key components. And this is from a study by Weinberg. Firstly, a focus on the treatment relationship, and I've already discussed how the key issue for the project-based strategy is really around relationships. An active therapist, attention to emotions, and exploratory change-orientated interventions. So what we've done is we've published treatment guidelines, which are mentioned quite a lot in the NHMRC guidelines, but really to try and help clinicians get the key messages around how to be helpful with BPD. These are on our website, and they're really just trying to reinforce a more positive, hopeful and empathic method and message to clinicians who want to do good work, but in the past have sort of been told that they can't do anything useful. In terms of step-down care, clearly people need to have hospitalisation if they're very, very unsafe. But actually most of the treatment that's evidence-based is outpatient treatment in the community. But we need to have a range of options to meet people's needs. And this is reinforced by, I guess, Sathya's comments that really we're talking about a high prevalence problem. This is the best data that we have. This is the Jackson and Burgess study on the Australian National Survey of Mental Health and Wellbeing. And essentially 6.5% of the population have a diagnosable personality disorder. This is from a very carefully controlled study of the Australian population, which comes out at about 1.5 million. This is in big contrast to schizophrenia, for example, which is a much lower prevalence of about 1%. We also looked at the presentations to emergency and inpatient units in public mental health services, and clearly, when you look at that data, about 25% of clients have personality disorder or related conditions. So not only are people being admitted and coming to emergency departments for bipolar or mood disorders or psychotic disorders, but also for personality disorders. So we're really talking about something that requires just more than a few specialised clinicians. We're talking about a high prevalence disorder that really hasn't had the public recognition that it needs. If you have an area health service, say a typical area health service of 14,000 people, then you've probably got 6,338 inpatients. This is data that we did from one particular study of a local health district. And of those, 1,584 unique people with a personality disorder presenting. So our estimates are that for most ordinary local health districts, about one person per day are presenting to or knocking on the door of the mental health service with a personality disorder as their primary diagnosis. This really is a challenge for us. So what can we do? Clearly, if we have lots and lots of DBT programs, I think Sathia's already given us some fairly sober data about how much that would cost and how many clinicians we would need to do it. But lots of people don't want or don't need or don't survive in long-term treatments. They, in fact, need step-down care. So sometimes when they're in crisis, they need a response, but when they're not in crisis, they live happily in the community. There's lots of different options that we need to be looking at. I think the comments about psychological services under Medicare is one part of the story that needs to be addressed. But there are also lots of other very high-quality non-government and government agencies that are doing and have the capacity to do good work. What we've done, therefore, is to try and provide a psychologically based alternative to hospitalisation and inpatient units. A brief intervention clinic where people can come and sit down and talk about their crisis, their problems right now, and get a sense of what it is that's troubling them and what are the possible things that they can do to help them. So the idea was to have a place for people to go within 1 to 3 days of presenting in crisis inside the mental health service to act as an intermediate point between those acute services and longer term treatment options, and to provide brief time-limited interventions that are going to help people make the next step in their life. It was based on an idea that was originally done at St Vincent's Hospital here in Sydney, called the Green Card Clinic. Thank you. We've developed a number of these. At the moment there are 6 brief LifeWorks interventions or Gold Card clinics. They've got different names, but they're essentially the same model of an alternative within the mental health service where people with BPD can go to these Gold Card clinics and get seen and get psychological counselling, and they can invite their families and carers in as part of that program and get a real orientation to what are the options that are facing them, what are some of the crisis skills that they can learn to overcome some of the behaviours, and to get orientated to either longer term treatments or to stable options in the community. One of the things that it's immediately done is prevented the kind of presentations to emergency and inpatient units that weren't helpful for BPD. We know that the best treatment for BPD is psychologically based interventions in the community. So hospitals often have a role to play but are not a primary treatment. What we've done is been able to reduce the number of people presenting to emergency departments and to inpatient units because we now have an alternative to meet their needs. Thank you. We've also reduced emergency presentations. Next slide, please. And then what we did was we thought, well, what happens to these people? So what we've been doing is following them up after 12 months and asking them, well, what happened to you? After you went to these brief intervention clinics, did your life improve? Did you actually get the services you need? Did you follow the guidelines and the help that we've offered? Clearly, yes. The answer is that people have found themselves in a much better place. They've got a proper diagnosis, they have a treatment plan, and their quality of life has significantly improved. Thank you. They're less depressed, they have less suicidal thoughts. Thank you. And I think most importantly, that people are actually being able to get back to work or to school. So TAFE, employment, university, other kinds of training are very, very important for people with mental health problems. We know that the fundamentals around being able to be in supported work is very, very important to really the recovery journey. And we're really happy that that's one of the things that seems to be coming out of this. Thank you. In terms of thinking about mental health services, while psychotherapy and intense interventions like DBT are very, very valuable, we don't have all of the staff that are trained. And there's a lot that other people who work in mental health services can do that is very, very useful for this client group. So what we've tried to do is think about a pyramid of training where everybody at level 1 and 2 gets at least some connection and assessment training and some general education and support training, and then other staff who are more specialised can get more consultation and psychotherapy training. So we've done a lot of workshops, we've set up a lot of training and structured activities for mental health staff to reorient them to BPD. This is some of the people who've been working with me in the training, some of them from Melbourne. Thank you. We've trained at the moment in this pilot study 1,764 at this really intense level. So the idea is to give them a lot of the new evidence around BPD, a lot of the new hopefulness around the effectiveness of treatments, but also to train them specifically in some of these relationship-oriented skills and how to use good clinical guidelines. Thank you. Thank you. We've been able to increase the staff's confidence and skills from that. Particularly, we were really happy with the specialist staff that we trained, so that those at the level 3, 4 and 5 who were doing the most intense training, they also were able to experience significant benefit from the training. Thank you. And clearly, if we just train mental health staff, then we'd only be doing half the job. So working closely with families and carers has been the other part of the strategy, which I think has been really important. We're working now on how to connect with employees and employers, so that the employers can provide and understand the people that they're taking on and do a better job in relationship to the hypersensitivity and the other kinds of issues that are likely to come up and make relationships difficult, so that they understand that more, how families and carers can be part of that journey. And also, I think, most importantly, to have a more hopeful view in the community around BPD. So in summary, the project strategy is really trying to look at a number of different options for improving personality disorders and a step care approach. To do whole of service training to enhance the support and attitudes, to enhance the clinical pathway so that people get the right treatment more quickly, and to strengthen the longer term treatment in the community by really recognising that there are good clinicians in the mental health service who can do the longer term psychotherapies like DBT, and ensuring that they get the kind of training and support that they need. To work with services on complex case reviews for high risk people, and we've been doing quite a bit of that as well, because there are some clients where the services, it's not a good match, and we're trying to really help services to rethink their strategies and to provide family care workshops, brief sessions and group interventions. There's a good reason to do all of this. Sathya's talked about the cost of providing all of these services, but there's a cost of not doing anything. If we look at the direct medical costs and the indirect costs, the saving per patient for providing good treatment per year is $8,000. Even though there's a initial cost to provide treatment, there's a saving that goes on for the rest of the person's life if you've done good treatment. And I think we've seen some examples of good treatment and how well people can come out of their shell and really be valuable contributors. So it's money well spent. It's hard when you say the initial cost is going to be this, but actually you're going to save a huge amount to do that. But I think we need to keep reinforcing the message that there's no alternative to providing good treatment. And if you'd like to learn more about what we're doing, this is our website. Thank you.
And there will be an opportunity to ask some questions a bit later on. I was thinking about Janelle's dad, Tony. I met someone recently whose name was Bradley Pitt, and he didn't really look anything like Bradley Pitt. And I just thought for most of his life it would have been kind of normal. And then about 12 years ago, or however long it was, suddenly every single time this Brad Pitt met anyone else, there would have been that, oh yeah, oh right, you're sort of short and fat. And, so it would have been irritating. He was talking a bit about, Britain was talking a bit about, or a lot of the